Moving on to our next high-yield condition, we have the hemothorax, in which the patient is classically going to present with unilateral decreased breath sounds, as well as dullness to percussion in the area where the blood is accumulating. This is classically going to occur following chest trauma. Additionally, with the patient's loss of blood, it should not be surprising to us that the patient can also present with hypovolemic shock, in which they will have flat neck veins, hypotension, and tachycardia. Additionally, these patients can also manifest with contralateral deviation of the trachea as the blood causes the trachea to move towards the opposite side of the chest. The pathophysiology of the hemothorax is a blood vessel injury. This can happen to one of several blood vessels in the chest in the context of chest trauma, including the aorta, the internal mammary vessels, as well as the intercostal vessels. Ultimately, we can manage hemothoraces with the use of a tube thoracostomy. This is sufficient in cases in which the blood that we extract from the hemothorax is less than 1,500 mLs. However, in cases where we have more than 1,500 mLs coming from this hemothorax, then these patients are going to require emergency surgery, often with a thoracotomy. Now, we should note right off the bat here that when we say tube thoracostomy, this is really the same thing as a chest tube. And this is essentially a plastic tube that is inserted into the pleural space, hence a chest tube. And we have included a schematic of a chest tube on the right-hand side of the presentation, where you can see that we are simply inserting this plastic tube into the pleural space in order to drain fluid, for example in the case of a hemothorax. Classically, this is placed at the fifth intercostal space at the mid-axillary line. And although this can be extremely helpful in allowing us to drain fluid, as is the case with our hemothorax patients, there are several complications that can occur during the placement of a chest tube, including clogging of the chest tube, air leaks, pulmonary edema, as well as pleural and pericardial effusions. And lastly, I would just like to make abundantly clear that when we say tube thoracostomy, this is referring to the insertion of this plastic chest tube, in contrast to a thoracotomy, in which we are actually breaking open the chest in order to be able to perform emergency surgery. Next up, we have an extremely high-yield discussion of the pneumothorax. It should be noted, however, that there are two major types of pneumothoraces, and these pneumothoraces differ in terms of their presentation, as well as how we diagnose them on our chest x-ray and how we manage them. These two types of pneumothoraces are the spontaneous pneumothorax and the tension pneumothorax, and we will now go through each of these in detail. In the case of the spontaneous pneumothorax, this is going to present with acute onset chest pain as well as shortness of breath, and patients, when they develop these spontaneous pneumothoraces, will often have these symptoms come on while they are simply resting, hence the term spontaneous pneumothorax. The spontaneous pneumothorax can be divided into two types, the first of which is the primary spontaneous pneumothorax, and the classic presentation for this is going to be a young, thin male, oftentimes a smoker. In contrast, in the case of secondary spontaneous pneumothoraces, our classic patient for this is going to have chronic underlying disease of the lung, most commonly COPD. In addition to the acute onset chest pain and shortness of breath that these patients have, on physical exam, they will classically have decreased breath sounds on the affected side, as well as increased resonance to percussion. And very high yield to keep in mind for examinations, the underlying pathophysiology of spontaneous pneumothoraces is the rupture of subpleural blebs. On chest x-ray, our patients with spontaneous pneumothoraces should have a clear visceral pleural line in which they have an absence of lung markings beyond this line. This can be appreciated in this patient's right side, where we can clearly see this visceral pleural line running here, and beyond this point we don't see any lung markings. This can also be contrasted with the opposite side, where we clearly see the presence of lung markings beyond that point on the opposite side, and this is highly characteristic of a spontaneous pneumothorax. We should also note here that the trachea in this case is pretty much midline, and this is also consistent with a spontaneous pneumothorax, in contrast to what we will see in the coming slides, which is a tension pneumothorax. And the reason that we emphasize this difference between spontaneous and tension pneumothoraces is because ultimately we are going to have differences in how we manage these two distinct conditions. When it comes to the spontaneous pneumothorax, the management of this is going to depend on the size of the pneumothorax as well as the patient's stability. If we have a patient with a small spontaneous pneumothorax, defined as being less than or equal to 2 centimeters, and that patient is stable, then we can simply monitor that patient and give supplemental oxygen, as this will often resolve their spontaneous pneumothorax. This is in contrast to our tension pneumothoraces, which are always going to require urgent intervention, regardless of size. However, in the case of spontaneous pneumothoraces, which are large, defined as being greater than 2 centimeters, then ultimately these patients will need either a needle decompression or a tube thoracostomy. We have included these two options here of our needle decompression as well as our tube thoracostomy or chest tube here. And in the ideal scenario, you would like to be able to place a chest tube or a tube thoracostomy. However, in cases where we do not have a chest tube available or where we can perform needle decompression more quickly, then we can often go with this as our option in terms of our management. Additionally, you can even perform a needle decompression initially and then ultimately move on to performing a chest tube later on once the patient is stabilized. And therefore, overall, when we're managing a patient with spontaneous pneumothorax, we really have three options in terms of their management: supplemental oxygen, needle decompression, or a chest tube. However, as we move into tension pneumothoraces, we will see that the needle decompression and chest tube are really our only two options for managing these patients. This leads us into our second type of pneumothorax, which is the tension pneumothorax. These patients are also going to present with acute onset chest pain as well as shortness of breath. Additionally, these patients will have similar physical exam findings, including decreased breath sounds as well as an increased resonance to percussion. However, in the case of the tension pneumothorax, especially with tracheal deviation and compression of the cardiopulmonary structures, these patients can often go on to develop unstable vital signs, including hypotension and tachycardia. And therefore, these patients typically will be more sick on presentation relative to our patients with spontaneous pneumothorax, whose primary concern is their pain and shortness of breath. Additionally, a tension pneumothorax, unlike a spontaneous pneumothorax, is not going to be spontaneous, but rather is going to have some sort of trigger in the exam vignette. Oftentimes, this can be the result of chest trauma, or in some cases, iatrogenic causes, such as classically mechanical ventilation. Our initial workup of a tension pneumothorax in the setting of chest trauma is often going to include a fast ultrasound assessment, as this is going to allow us to assess for the presence of a pneumothorax even before we go on to get our chest x-ray. However, if we do go on to perform a chest x-ray, we are still going to see this classic visceral pleural line, as well as an absence of lung markings beyond this line. This can be appreciated in this chest x-ray on the right-hand side of the presentation, where we can see that in this patient's right lung, we see lung markings all the way throughout the field, whereas on the left lung, we can see that we have this clear visceral pleural line with a lack of lung markings beyond this line, and this is highly characteristic of pneumothoraces in general. However, what you really want to look out for on your examinations to distinguish a tension pneumo from a spontaneous pneumo is that for a tension pneumothorax, we are classically going to see tracheal deviation away from the affected side. This can also be appreciated in our chest x-ray on the right-hand side of the presentation, where we can see that this patient's left side is affected and thus the trachea is deviated towards the right, and this is highly characteristic of a tension pneumothorax. And in the case of this tension pneumothorax with deviation of the trachea, which can ultimately compress on local structures and cause the patient to become less stable in terms of their hemodynamics, these patients are going to require urgent intervention. We cannot be simply giving these patients supplemental oxygen and expect this defect to resolve on its own, and therefore patients with tension pneumothoraces are absolutely going to need either an urgent chest tube or a needle decompression in order to resolve this condition.